So welcome to the show. I'm your host, Dr. Joseph Coppus, and today I am joined by my guest, Eric Dinkins. Thank you for joining me today.
Great to be here, Joe. Thank you for having me on.
Yeah. So you work with and you helped create the motion guidance technology, correct?
That is correct.
Okay. So this is a technology, this is something, a therapy application that we in this clinic use pretty much every day and see great things with it. So I'm really excited to hear you speak more about maybe some applications for different things like concussion, etc. today. So
sure. Yeah, well, I can always just start with the device and the background of it. Obviously, like you said, you're familiar with it. And you used a little bit of a pun there by saying that we see great results with it, because the idea of the device was being able to place visual feedback as a representation of movement on any body part. So the actual genesis of the device was myself and my partner, my business partner, Tal Blair. We were both physical therapists, and we were using homemade laser pointers essentially that had some difficulty with them to help the people see what they were doing in real time, and just as importantly help us see what they were doing in real time. And just over about a 5-year period, we developed a ball and socket type laser and a belt system that you can put anywhere that's lightweight, very mobile, but also very stable to allow you to see what's actually happening in real time with your patients.
Excellent. So what you said you're a physical therapist. What I guess was the inspiration behind developing this application? Sure.
Well, originally we were looking at squat mechanics in my clinic. So the first 5 years that I was in practice, I worked in sports medicine with a local physician group that had the contract with the local sports teams here in Denver. And so we were very much into knees and shoulders at the time. So there was a lot of risk associated with return to sport and ACLs and things like that. And so we were looking at providing a way for people to understand how they were moving, especially under load. And that's where it kind of broke down, was people could do things in single limb or double limb stance and they could understand how to correct it. But when they were moving or when they added load, they couldn't see that. And so we decided to start fastening different types of laser pointers to different body parts to help them see if they were going through uncontrolled movements of valgus or instability portions. And what we found was actually quite amazing, because a person could do like a single limb squat and they could get depth and they could get control. Subtle things you pick up with later would kind of do a loop on return to, and that was very it shows we couldn't see in real time either.
Okay. So when the athlete is going through these different motions and then they have the added the feedback from the laser and the motion guidance, and they can see how their limb is moving, how does that kind of work in the brain per se to allow them to, I guess, self-correct what they're doing?
Well, I think you touched on some key words there, is self-correct. If we kind of start with foundations of just learning and preference of styles of learning, everybody understands that for the most part, people fall into a preferred learning style of 3 different silos. You have the auditory preferred feedback of listening to how things are done or instructional things. The kinesthetic awareness of being able to feel it or get some sort of body feedback with how they're getting their instruction. And then you also have the visual realm of, when I see it, I understand it, and that's how I learn. The interesting part is when we start talking about motor planning, when we start talking about developing motor skills, at least in the novice phase of doing that, something that might be unfamiliar, the preferred learning style ends up being visual. In some research, it pushes all the way up to 92% for gaining a skill and then also retaining it. The contradiction to that is classically, clinically, most practitioners are still using auditory and kinesthetic feedback to direct people in how they learn those skills. So at the time, with lower limb mechanics, the visual feedback, we really saw a great acceleration in how our people, our clients would understand their movement, and then be able to self-correct instead of us always jumping in and correcting in real time based on touching them or telling them they were doing it incorrectly or something like that.
Mm-hmm. Yeah. Okay. Very cool. Very cool. So we work with a lot of concussion and dizziness patients in this clinic. How can your technology be applied to those patients? And
Sure. Well, that's definitely the evolution of how a lot of people see the value in visual feedback. I think there's a lot of people across the world actually that understand with the vestibular patient, with the whiplash patient, with the concussion patient, that they automatically use the laser visual feedback for either assessing joint position sense error at the patient, at the head neck, or with motor control. What they tend not to see is that they can use it far more for assessments of like ocular motor things, giving an external focus of attention and motivational pieces to people when they're trying to understand what's happening with their body. And that population is understood by practitioners. They have a deficit in how the world sits. They have a deficit typically of their vestibular or their ocular motor system telling them that they're not quite right, and that's why their symptoms persist over time, but they don't know what's happening during that time. And so there's a couple examples, if you'd like me to go through, of ways that you could use the motion guidance system to enhance those particular realms of assessment and treatment, during our 45 minutes to an hour here, if you think we have time.
Yeah, that would be absolutely great.
Great. So if we take a general vestibular and ocular motor assessment tool like the VOMS, which a lot of people are using for concussion, the VOMS is nice because it breaks down different reflexes and systems in the body that we would consider to be normal for the typical person, and then we compare those against a concussion or whiplash person. And then we draw from other research to kind of complete the exam and see if those people are normal. If you take something as simple as saccades, which is a reflex of the eyes being able to move between targets in the visual realm while not moving the head, while not having to move the head. Oftentimes concussion, whiplash, or neck pain patients will have what we refer to as like a motor cheat. So their eyes will be able to move, but they'll have to move their head one way or the other. And usually it's a unilateral thing. Whenever my eyes move to the right, my head has to kind of go to that side, but I can move my eyes to the left without having to move my head. So on assessment, if you have a laser on a person's head, with like the motion guidance setup, you can have them looking straight ahead, and then you can have the laser pointed either directly in their visual field ahead or above them in the midline, and then ask them to go between two targets side to side with their eyes. And if you see that laser moving, you know that they're actually creating a small motor cheat. And the most important thing is that they can see it too. Mm-hmm. So in real time, you get a very specific reflex response on whether their body's acting normally or not, and then you can start increasing speeds with a metronome and have them work up to where they fall into a standard category of normal.
Absolutely. That's a really good application that I hadn't really thought about. Is trying to just use what I can perceive bedside, but this is much more fine-tuned, I think, than what much more easier to see than I think what our eyes can pick up bedside, and the patient can see it then too. And do you find that with repetition, patients get the feedback from the laser, and then they're able to self-correct just like other joints of the body, like the lower extremity we were talking about earlier?
Oh, for sure. I think the value there is them understanding, and of course, then the goal is to not have to use the laser,
Mm-hmm.
right? So they go, well, I've learned and I know what that is. So if they can't move in a saccadic rhythm very well, whether it's on a straight axis of horizontal or vertical, like the VOMS tells us to do, or whether it's more in a seated cervical rotation position, which might bring in other sensory inputs from the neck. Or on a diagonal, they gauge, well, how fast can I move my eyes and not move the laser?
Mm-hmm.
And that gives valuable feedback. So that also helps you as a clinician set that metronome to where you go, okay, 50 beats per minute is way too fast for you to be able to do this. Like, you just can't keep up.
Yeah.
So let's set this to 30 beats per minute, which stimulates a little bit of your symptom, but then we recover in a reasonable period of time, usually between 2 and 5 minutes.
Mm-hmm.
And then we can keep working that metronome up, and it gives an easy gradient for the clinician to actually improve their patient's performance instead of just guessing how overstimulated they're going to get.
Absolutely. So what are some other applications that you see with head injuries and eye movements and the interplay that head and eye has?
Sure. So we also have things like a VOR, so times one viewing. So people are trying to move back and forth and keep a fixed point. So classically, we'll have them look at their thumb or the tip of a pen or something like that, and have them move back and forth at a certain cadence. That one can be also pretty standardized, and some people can correct that really well. Some people, it makes them dizzy over and over. If you add in the laser feedback to their head going side to side, you can not only watch their response to their eyes, but you can see if they have abnormal tracking side to side. So some people will go toward, I'm actually doing that off axis. So you'll start to see the laser move at a little bit of an angled pattern side to side, and they can master that and actually say, okay, well, my world is slightly off axis, I do fine. Saying no, and fixing a gaze. But if I have to get completely upright, that still bothers me. Well, so either they adapt their world to being a little bit off kilter, and that's what they're doing, driving around at 75 miles an hour, taking embankments at a little bit of a curve. Or we can show them that, hey, you need to line this up on this horizontal line on this motion guidance flag, and as you're going back and forth, we want to see that laser is also going back and forth at a level line. So it actually can be adapted to that, where you see something as normal, but then when you go retest it with some visual feedback, you go, maybe not. Even subtle things like a titubation. So as I start to get ocular motor movement at the head, and I start to see some irregularities of like how you start to control that to one side. So you start seeing either ticks or little up and down movements of the laser, irregularly. The further back from the flag you get, those can be really enhanced to give you feedback on, you might not see that from a distance like I am from my computer screen, but you put the laser on there and you can really start to see things change, side to side. So the expert eye, of course, the clinician who's done this for years and they've seen thousands of patients, they might not need a tool that gives them that much information. They see it right away. But especially for the patient who might not be turning the corner, the clinician who is fairly new to practice or looking at these types of things, it can be very valuable information for them.
Absolutely. And then, in addition, you were talking about the straight horizontal plane that the flag has, that you can do these times zero VORs in, or these eye head movements, but there's also different like sinusoidal or like infinity types of patterns that you can track. And how does that interplay, and when would you use those?
Well, sure. As you're probably familiar with, anytime you start getting into what we might refer to as like a complex movement pattern, versus a straight plane, horizontal or vertical type of pattern, which can be recruited from like a frontal lobe type of input. And when you get into those complex movement patterns, your cerebellum really has to start kicking in and linking into the thalamus for prediction and other, areas of the brain, the deep areas of the brain that are kind of recruiting from whatever they can to make sure that normal is processed, and therefore you get a normal motor output from the environment. And so, like you mentioned, if you're doing that from the head and doing like an infinity sign, that could be much more difficult than just walking down the street, having to look up in a gaze and find what normal is. Or you can recruit similar patterns in the brain by putting the laser on an arm and starting to do infinity patterns of complex movements to just create input through certain areas of the brain to try to establish that you're being uptrained rather than overloaded.
Right.
So the flag definitely allows for that by having that infinity or that flower sign or pattern that's on there in different levels. 3 different levels on our flag that comes with the kit. And then the clinician can utilize that as they want to. And I think that's one of the hidden gems of the motion guidance tool is while we definitely create protocols based on research, we allow people like Dr. Joe to say, well, I think for this particular patient, I need to use this differently. I need to kind of get this done a different way. And so the portability of it, the usability in different areas of your clinic allows you to kind of create whichever you want.
Absolutely. That's great. So I think one of the big things that I've really liked using the motion guidance with is with different types of cervicogenic dizziness has been huge, and kind of reestablishing the proprioceptive feedback from the neck into the brain. What are some applications that you've seen that have been successful for these types of patients?
Well, it definitely directed that we've known about for a little bit over a decade is the influence of joint position sense error in neck and cervicogenic dizziness, especially in the whiplash population. But now we're starting to see it in concussion. We're starting to see it in migraine patients sometimes, cervicogenic headache. So the tool actually allows a very simple application of assessment from a standardized distance from the flag. We put people 100 centimeters from the flag. That's the international standard. We have them look over their shoulder after we've lined up the laser on our target 3 times with their eyes open. You come back to what they think is the midline, and then we have them close their eyes and look all the way over a shoulder, come back, and there's a standard deviation on our flag that if they are inside that target, not necessarily bullseye, but anywhere inside that target, then that would be a negative for joint position sense. If they're outside the target, it'd be a positive for an error. And you need 3 out of 6 repetitions to be outside that standard deviation. The nice part there is that that's always been touted as an assessment tool, but of course that goes right into treatment also. Be like, well, we're going to put you in this position or other positions, and have you be able to come back to this particular standard, and you need to learn from that. So if you are classically high and to the right in that upper quadrant, when you return and you're outside the standard deviation, understand that that is not your typical start position. You need to come back before opening your eyes and drop that into the left side and realize that that's going to be normal and not abnormal for you. So people can just train it. And I'm not sure what you found in your practice, but in my practice, 1 or 2 sessions of just a few repetitions of learning what joint position sense neutral is for them, it corrects. They don't need it's not a longevity treatment of 5 times a day for 6 weeks, and this will finally correct it. They can learn it pretty quickly.
Yeah, very good. And then, something I found, like if a patient has a hard time finding center, you can use, we talked about different types of feedback, such as auditory and whatnot. So you can use like an auditory stimulus in the middle to potentially help guide them and then retrain that proprioceptive feedback as well, I believe.
Well, and I love that. Nothing says that using a certain device is going to be a cure-all for people or that it'll assess all their needs. So we talked about different learning styles earlier, or different things. If you're using some visual feedback, which most people are not in their clinic, but if you're using that, you want to combine that with other things for sure. You want to combine that with auditory cueing. Combine it with other movement patterns, give them some kinesthetic awareness in certain things of what they're doing. There's nothing wrong with that. In fact, we want to maximize whatever we can to get results. for our patients, and preferably as quick as possible.
Yeah.
Yeah, which fits into some models of treatment and doesn't fit into others. But that's a great point. On the neck vestibular range, we also have infinity walking, which would utilize the ability of having you be able to move the neck but fix a gaze, and while you're getting proprioceptive awareness of your environment. So classically I'd start with either 2 foam rolls or 2 very large cones in my clinic that are set up a standardized distance for people, and then they start in the middle with the laser fixed at a point, like a door or a target, and they have to keep the laser on that target as they walk around each foam roller in a figure 8 or an infinity pattern. So you're getting neck movement, you're getting vestibular input for sure, you're getting an expectation of what's a successful thing by how much they can fix that gaze into a target in front of them, and that can be a fill in the gap exercise that if you're unsure what system's dominating the overflow of their bucket for their symptoms, that can kind of be a catch-all, because you're kind of getting everything in that one. And every clinician probably has their go-to in the sense of, well, I use this, or I've found that to be too much and I resort to this, and I think that all that's just fantastic. So.
Yeah. And I love that example because it kind of shows you how creative you can really get with the motion guidance system. Because there's a lot you can do with a lot of different issues, and I think the possibilities are near endless. So
for sure, yeah, and that's hopefully the adaptability and flexibility is what you need in a clinic. I know that we tend to label things. Well, I think this person has post-concussive syndrome. I think this person has whiplash. I think this person has neck strain, cervicogenic headache. They have shoulder impingement that's actually, driving all this, whatever that means, sort of thing. And I think that each patient presents an opportunity to allow you to be somewhat plastic or adaptable into your treatment. If whatever you apply works, then fantastic, it works. It's usually the people who they need something else. It's not going away, or it's only going away for a small amount of time. You need to be able to adapt your treatment to fit their needs, and hopefully our tool allows people to do that in various ways. Like you said, get creative with it.
Absolutely. And on this podcast, we've talked often about how every head injury is often different, or no head injury is the same, and that often goes for every neck injury, every shoulder injury. So yeah, I think this technology definitely gives us that adaptability, which I've really come to appreciate. Yeah,
for sure.
So give us a few other applications that maybe I haven't thought about, or maybe your clinicians listening haven't really thought about.
For that particular population?
Any population, but yeah, okay. Let's keep it mostly concussion, whiplash types of populations.
Well, one thing that when we talk about concussion, we have to talk about at least where the research tells us to go, and that's going to be 3 main silos of how we want to include in every concussion patient, with the understanding that our concussion treatments are definitely changing over time. So I would like to really point out that I think that while we have concussion specialists out there and we have NFL concussion screening, we are still figuring this out. This is not we know what this is. It's white matter, not gray matter. It's gray matter, not white matter. It's it involves these systems. These are our gold standards for assessing this stuff. We are still in a realm of rehab medicine and concussion that I think that we are trying to figure out what to apply to our patients. So the 3 main silos that I treat off of are going to be subthreshold aerobic activity. Get people moving. You might have 24 to 72 hours of recovery in the sense of, hey, take it easy a tiny bit and that sort of thing. But most research studies are leaning us toward, especially in the young adult or the adolescent population, get them moving fairly quickly in a sub-threshold way. Focus on returning their sleep patterns to normal is the second silo. So whether that's homeopathic improvement from things like melatonin or a warm glass of milk before you go to bed, or just things as significant as a sleep log, making sure your technology time is reduced 2 hours before you go to bed, things like that. Having a typical eating time before you go to bed, sort of thing. We try to work on their sleep patterns, but then we go into the physical medicine silo, which is going to be not only the things we've already discussed, but other aspects of how can I put my symptom provocative patient into positions and then work those positions. So to just come full circle to your question, things like midline cerebellar activities can be super powerful for a person who doesn't know how to change their environment and not have symptoms, which would be like a quadruped position. So we typically would take a person who has low back pain or what we define as core instability, once again, whatever that means, and do like a bird dog type of exercise. And so for patients who are listening, you put people on all fours and you extend an arm and then you extend an opposite leg and you try to hold that position. And people might say, hey, try to hold it for a certain period of time, or let's put a cone or a ball or a stick on your back and see if you can hold that. I've never quite understood why we're doing those, because when you ask clinicians why they're doing that, it's just like, well, so that they can hold it and that makes them stable. And I'm not sure that that's the best answer. However, it can be very effective for people. But if you adapt that into a concussion or a vestibular protocol, you're definitely going to recruit a certain area of the cerebellum and different areas of the brain if you put them in a horizontal plane in quadruped. And that might make them actually uncomfortable for different reasons than a back pain patient. So if you were to put the motion guidance laser around their torso or around their pelvis, and you say, I'm going to have you extend your right arm and extend your left leg, and you notice that their strategy, one side versus another, is different, it gives you immediate input on what you might need to add into their treatment program to normalize how their sensory perception of the world is. And that's something that typically is not provided in rehab clinics, is have them targeted underneath their hands and knees position, and when they go to move, you notice that when their right arm is out and their left leg is back, that laser moves off the target every single time in order for them to gain that position. But when they do the opposite position or opposite side, they stay directly in line. That might be a head-neck input type of thing that you need to address. And of course, you could do that same thing by putting a laser on their head as well. But I don't think that gets you the same feedback as what you're doing in the torso. So that'd be one example of a different application of visual feedback applied to a population that's not directed toward their head and neck area.
Absolutely. So you, I know you sell clinician kits and then at-home kits. Are patients able to just hop online and pick up a kit and try to play around with this at home, or what would you recommend as far as that goes?
Yes, to answer your question, we have a clinician kit that people can look at, which ends up being a low cost, below $300 kit that gets you started with everything you pretty much need, like you have in your clinic. And then we also have a patient pack, which is a streamlined version of an application typically intended toward one body part. So like a concussion person would get our head neck patient pack. Online. They could go directly to www.motionguidance.com, click on the clinician pack, and for $69 have it shipped to their house. As a clinician, you can also buy those in bulk and start either distributing those to your patient for less of a cost than what we would sell in our online Shopify platform. Or we have people that buy those and then they just give those out to their patient because it's included in the cost of their visits of what they need. And that way you have a nice carryover of learning that they can do on their own at home, and not just in their clinic. Some people can only come in once a week. Some people travel enough that they won't be home for 2 weeks before they could see you again. And those are the people that are usually getting the device for home use. And it comes with a flag. It comes with everything you need to recreate what you were using in clinic.
Perfect. And then you would recommend that, of course, a patient has a physician explain what they need to do before they, try to play around, or are there a lot of at-home applications that a patient can pick up on their own?
Yeah, there's definitely room for both. We always recommend, especially when you're talking about concussion or whiplash or head neck vestibular type of things, you need to get assessed. Yeah. You should always get assessed, because while we have standardized assessments, I've seen plenty of people that you go through the assessment process and their reflexes are normal with their eyes, their vestibular inputs are normal, and it's like, okay, so what have you been getting treatment for? And they're like, well, the clinician tilts me back and they drop my head to the side, and I get dizzy for a second, and then it goes away, and I still have all my symptoms. And you realize that, well, we're missing pieces. You just can't silo somebody into, hey, you have dizziness when you look over your right shoulder, therefore it's an inner ear problem. There can be several other inputs. So you should always get assessed. That being said, for people who either feel like they're not improving, or they have a distance issue, which can happen right now in rural America, people getting appropriate care. We do have information in our patient packs that allows people to either go seek out the proper initiation of treatments on our website with videos on our YouTube channel, or would allow someone like yourself to say, well, I can do a video conference or a video chat with a patient and say, you've either come in and I've assessed you, or, hey, I want you to do these things while I'm looking right at you right now. Get a little closer to the camera for me. And based on that, I want you to use this laser to do this and this and this exercise.
Okay. Very good. Very cool. So yeah, sounds like a lot of good options for patients out there,
right? For
clinicians as well.
We hope so.
Yeah. So we are just about out of time. So okay. I wanted to give you an opportunity to give us any final thoughts on the product and any further applications that you wanted to share with us today.
Sure. I mean, we can finish up with just the bare bones of it. People can find more information on our website, which I mentioned earlier, motionguidance.com. You can find us on social media channels on Facebook and Instagram and Twitter, at Motion Guidance, for all those types of things. Whether you are seeking out information about a certain body part or injury, we have those subsetted on our website. We give out examples and periodically tutorials on our social media channels. And we also have things like webinars that you can access on our website. If you have purchased a product from us that you can access for free right now, just to get more information about applications anywhere, because it's not so much about the diagnosis as much as it is about applying motor learning strategies, giving the patient what they might succeed best with by adding visual feedback.
Mm-hmm. You said you also had YouTube videos or YouTube channel that
correct.
Like to promote? Okay. Yeah. Very good. And the website one more time?
www.motionguidance.com.
Easy enough.
Yeah.
Okay. Well, Eric, I really appreciate you coming on and sharing this information about the motion guidance. I think patients and clinicians listening are going to get a lot of good feedback a lot of good information from this. So I'm excited to get this out there.
All right. Thank you very much for your time, Joe.
Yeah.
And having me on.
Yep. Have a good one. And this
You
has
too.
been your host from the Neuro Wellness Podcast. Be well.